and we'll go ahead and get started. So first, just want to welcome everyone. This is our second MAGS Cleft seminar series. If you're not familiar with the MAGS program, that is Smile Train's Mentoring Alliance for Global Speech program. We are in our third cohort of the program. We've had over 250 speech pathologists, speech providers from around the world participate in this program. And what it is a virtual cleft speech mentorship program with mentors and mentees from around the world, honing their skills, sharing expertise, sharing learnings, and it's really been a wonderful program. I know many here are part of or have been part of the program, so we're very grateful to those of you who have been part of the program. And if you're interested, feel free to send along a message to one of our emails. We'll enter that into the chat, and we can always send you some more information for future cohorts. So as I mentioned, this is our second cleft seminar series. After our first cohort, we had some feedback that our MAGS participants were interested and were yearning for webinar series focused on cleft speech care, particularly with a focus on low resource context. So this is a second webinar we're hosting, and this is a really, I think, important and relevant topic that we've decided on for this webinar with support from our co-leads and co-leads of the webinar here. And the title is Don't Wait, Treat, Effective Speech Therapy in the Presence of VPI. And so today we're really going to talk about, with a focus on low resource context, what do I do when I know that I see VPI, I hear VPI, but maybe I don't have access to a surgeon who has those expertise, or I'm not sure if I can treat immediately. And it's going to be a really valuable webinar. We have a couple of speakers, a couple of moderators who we will introduce shortly. But just want to thank you all so much for being here and realize that I did not introduce myself, which I will do quickly and then pass along to our moderator, our facilitator for the day. So my name is Sarah Horn. I am Smile Train's Director of Education and Training, as well as Global Speech and Hearing Lead. I'm a speech language pathologist. I know many of you on this call, and just very grateful to be here and to be able to put this on for you. And with that, I'm going to pass over to Darcy Abrams, who has coordinated this whole session for us. So a huge thanks to her, and she's going to talk through what we're doing today. Thank you.
Good morning, good afternoon, good evening. Thank you everyone for being here. We're very excited to have you all. My name is Darcy Abrams. I am the Manager of Research and Education here at Smile Train and one of the coordinators for the MAGS program here at Smile Train. Very excited for a great session today. As an overview of what we will cover, we're going to start by introducing our panel, which will happen as soon as I finish talking. We will have a seminar as well as case studies. This will last approximately 45 minutes. And then we are going to open the seminar up for discussion. This will include a panel discussion by our speakers, moderated by Dr. Kate Crowley, and as well as an opportunity for you to ask your questions and have them answered by our experts. And then at the conclusion of the seminar today, we will have a brief a second poll that we'll be asking you to take. Just to keep things moving, we do ask that you please keep your microphone muted. Do not turn your microphone on unless we explicitly ask you to. If you have questions during the seminar, please put them into the chat. We will not be stopping the presentation to answer questions, but we will make sure to answer all the questions at the conclusion after the speakers have finished presenting. So before we begin, we do have a poll that we would ask you all to participate in. These are a few brief questions about your experience. We love to get an understanding of who is here, individuals' expertise and practice, and already existing practices that you might have. So please take a few minutes to respond to this poll, and then we will move on. Okay, we're waiting for a few more people to respond. So far, we have 19, 20 individuals. Please keep putting your answers in. We'll give it 1 or 2 more minutes. All right, we're going to wrap up and close the poll. Thank you to everybody who responded. It seems like years of practice, we have a really nice distribution of individuals who are newer in their speech profession, as well as those who are older, having worked for, I shouldn't say older, excuse me, more experienced, having worked for 10 or more years in the field. Also a wide range of the number of cleft patients treated per month. So thank you all for being here and contributing to this discussion. We really appreciate that. And now it is my pleasure to introduce the speakers today. These are our facilitators and our cleft speech experts. We're very thrilled that they are all here. First, we have Mr. Eduardo Ajasin. He is a speech language pathologist working in the country of Benin. He's been running his own practice since 2019, teaching at speech language pathology schools. He also trains new recruits for community-based interventions in Francophone Africa. He also represents speech therapy at the African level within the African Medical Advisory Council at SmileTrain. Next, currently working as the head of speech and hearing department at the Hospital for Rehabilitation and Craniofacial Anomalies at the University of São Paulo, we have Dr. Melissa Zattoni Antonelli. She is a speech and hearing pathologist experienced in craniofacial anomalies since 2003. She's a member of the craniofacial interdisciplinary team since 2009. She has a PhD in the same area since 2010, and she is a tutor in the multi-professional health residency program since 2022. As our moderate, we have Dr. Kate Crowley. She is a professor of practice at Teachers College, Columbia University. She has led over 35-day intensive cleft speech trainings across 5 different continents. As an ASHA Fellow, an honors recipient, and member of SmileTrain's Global Medical Advisory Board, her international work focuses on building capacity so children with repaired cleft palates receive quality speech services. Dr. Crowley's website, leadersproject.org, offers free cleft speech resources in over 40 languages and is accessed by over 90,000 users per month. And we also have Ms. Jackie Kukoff. She is a speech language pathologist on the cleft and craniofacial team at UCSF Benioff Children's Hospital in Oakland, California, in the United States. She specializes in the assessment and treatment of speech and resonance disorders with a focus on velopharyngeal insufficiency. Jackie is passionate about advancing research and global collaboration in speech. As a final reminder, please keep your microphones muted. We will monitor the chat, answer when we can, and we'll bring up for discussions questions that are relevant to the group. Please also, if your name is incorrect on your Zoom account as it's showing, please update that so we know who is here and who is speaking. And with that, I am pleased to introduce our first speaker, Mr. Eduardo Ajasin. Eduardo?
Thank you, Darcy. Thank you, everyone, for having me. I'm very happy to be part of this conference, to this webinar. Before starting, I want our participants to note that I am not a good English speaker. I'm a francophone, so I will try to do my best. That is why I make my PowerPoint as clear as possible, so you can understand without a great explanation. So this topic is a very exciting one. Next, please. When we have patients after operation, our expectation as a speech therapist is to get a patient that we can train easily to bring him speak easily. But we discover sometimes that it is not easy because many of those patients has a issue. The issue they still have sometimes is the velopharyngeal dysfunction. So we are talking today about the VPD, velopharyngeal insufficient VPI, sorry, velopharyngeal insufficiency, which is a structural problem, but this can be part of many kind of problem we used to we used to meet with our patient. So I'm going to make a difference between the VPI, what is a structural problem, and VPD, which is an umbrella term who engage three kind of issues. Next, please. So, like I said, um, patients face a problem, they face issue to close the velopharyngeal mechanism, to have a good velopharyngeal mechanism. We all know that to have a good closure, we need a soft palate, a posterior pharyngeal wall, and the lateral pharyngeal walls. And those are the first important things we have to know before getting. So even after operation, this closure may not be possible. It may not be possible. Next, please. It may not be possible because the patient can have a velopharyngeal insufficiency or a velopharyngeal incompetence, which is a functional problem, and the patient can also have a velopharyngeal mislearning, which is related to a difficulty to learn how to use the velum. So the velopharyngeal insufficiency is a structural problem which cannot be easily targeted handled by the therapy, but need surgery. The VPI is common causes by a cleft palate, a short or immobile velum, a submucous cleft palate, or a post-adenoidectomy gap. Next, please. What are the impacts of VPI on the speech? We have three kinds of impact on the speech. The first one is hypernasality. The second one is nasal air emission. And the third one is a weak pressure consonants. When the patient has a VPI and is not able to have a velopharyngeal closure, his voice may sound excessively nasal due to unintended coupling of oral and nasal cavities. For example, the patient may want to say baba, and that baba will sound like mama because b is an oral sound who will be replaced by a nasal sound, m. The second impact is the nasal air emission. And the nasal air emission is like a turbulence who can be audible or not audible. It is usually it occurs usually in accompaniment of the sound. The patient can be making the sound like he is making the sound s, but the sound is accompanied by a nasal air emission. So the s may sound like s, so you hear a turbulence through the nose. Sometimes you can confuse the hypernasality and the nasal air emission, but The simple way to make the difference between both of them is that hypernasality is simply like a replacement of oral sound by nasal sounds, but air emission is a nasal air which passes through the nose when the patient is making sound, especially the fricatives. Nasal air emission can be permanent or can be specific to some sounds. So the third problem is weak pressure consonants in the best ways. In the worst way, the patients may not be able to make the consonants because the oral pressure is reduced or impossible. So the patients may want to say a p sound, but that p sound will sound like a b. That is in the best situation when the patient is already trained. Normally, if the patient is not already trained on the placement, you may not hear anything coming from him. Next, please. So what is the therapy role when we are facing a VPI? The therapy can change and what cannot be changed? If we have a patient with VPI, therapy cannot fix the VPI because it is a structural problem who needs surgery, like a short or absent velum, like a fistula, persistent velopharyngeal gap after palate repair, or a submucous cleft tissue deficiency. This requires surgical or prosthetic intervention only. But that is not a reason for no treatment. We have to treat the patient because even if there is a VPI, some his speech can be a little bit improved. So that's why we have to tackle articulation, placement, and the precision because we can change that. We can make the patient having the good placement to articulate the sounds. We can also reduce the compensatory articulation errors with the therapy. We can help the patient manage the airflow. And we can also have the patient having a good intelligibility and a functional communication participation. Because if the patient is able to do the sounds, especially the placement of the sounds, even if the sound is not correct, that will make his intelligibility better. So the patient who still has a VPI issue after therapy will be able to speak so that we can understand. People can understand him. He will be more intelligible. But that doesn't mean that we accept the way he speaks. We all know, we realize that he still has a problem. But because he is now able to make at least the placement of the sound, he will be able to be understood. Next. Melissa, over to you.
Oh, can you hear me? Yeah. Hi,
Yes.
everyone. Can you just go back for the other slide, Darcy, please? Yes, thank you. Thank you, Sarah, Darcy, for having me. It's such an honor to be here. And as we begin this segment, I wanted to look at the target symbol, remembering that in cleft palate speech therapy, it's not just about making sounds. It's about hitting the mark of developmentally appropriate speech. So while the challenges of cleft palate are complex, our goal is to ensure these children have the same communication opportunity as their peers by the time they reach school age. Okay. Next, please. So to treat these children effectively, we must understand this big divide. So in one side, we have what can be compared to hardware glitches, The category we clinically call obligatory or passive errors, and they are caused by anatomy, like a leaky valve, meaning insufficient velopharyngeal mechanism, or a fistula, for example. And we should know that therapy cannot fix this. Hypernasality and weak pressure are obligatory, so they require surgery or prosthesis. We can also use missing teeth or malocclusion that result in oral air escape, for example, of hardware glitches that cause passive errors, but these are not related to VPI. So that's the difference. On the other hand, we have what can be called the software glitches, clinically known as compensatory errors or active errors. And these are bad habits the brain develops to bypass the broken hardware. So they are active errors like glottal stops or pharyngeal fricatives, and we're going to talk a little bit more about them. So the therapist, the speech therapist, is the one who is going to rewire the motor plan. Surgery cannot treat these errors, the compensatory errors, because they are learned. So hardware solutions cannot solve software problems, right? So next one, please. So let's take a look at some of the main bugs. The glottal stop, this is one of the most common errors. The child uses the throat to punch out sounds because they can't build pressure in the mouth, right? So that's the very characteristic sound. And then we have, for example, a nasal fricative. And here the child intentionally forces air out of the nose for sounds like s or z, right? And then we have pharyngeal sounds. This involves moving the tongue too far back, creating deep throat sounds. And sorry. So the child has the structures to produce some sounds correctly, but they are just not using them. And then before we think about correcting them, we need to identify them. It's very important that a speech pathologist that is not experienced in cleft speech can be properly trained to identify these errors correctly. So in Brazil, we say something like train the ears, because the differentiation between a glottal stop and a pharyngeal stop is good, is important, but not as important as the differentiation between a nasal fricative and nasal emission, for example, because this would be a passive error, or between a pharyngeal fricative and a lateralization, the distortion, because the treatment will be very different. So the first step is the correct diagnosis between hardware and software problems, and then considering the category of software glitches, the correct identification of the articulatory mistakes. Next slide, please. And then why we don't wait for perfect hardware? Many systems follow option A, right? Wait for surgery and then start therapy. And this can be a mistake that will lead to years of ingrained bad habits. So we advocate for option B, start therapy now by upgrading the software. Today we can teach the brain the correct placement, just like Eduardo was saying, of tongue and lips, and even if air pressure isn't perfect yet. So this can prepare the child for surgery, and in some cases, intensive therapy, for example, can resolve mislearning. So effectively, that extra surgery can be sometimes avoided. So next slide, please. And then how do we do that? How do we hack a system that is not great, not perfect, right? We have some hacks. So we use nasal occlusion, for example, where we physically pinch the nose to force the brain to experience oral airflow. And this help shape sounds like B from M, for example, D from N, and it can also work as the initial step for oral sounds. And we sometimes keep this strategy, sometimes when patients really have a VPI, and we can go ahead using this. And we also use visual feedback, something as simple as a tissue in front of the mouth, for example, can prove to the child that the air is moving forward, not up. And we also use a lot here the foam beads in a cup, for example, so the child can see the air coming out of the mouth. Another example, for example, to teach an S, we have the child tap a T repeatedly, and then stretch the final one to an S. So those are examples of hacks, right? But I think the next slide is very important as well, where we need to think that this is a step-by-step process. So we use this speech hierarchy. We start with isolated sounds, so using visual, hearing cues, sometimes nasal pinching, and then we move to syllables and words. And before this step of words, we frequently use pseudo words or non-words, and so then we go to the words. So and then sentences before we ever expecting mastering spontaneous conversation, that would be the last step, right? Next one, please. This is so very important. We need to have the family, right? The role of the family is amazing, and then the patient can go through a very different way when patients are present and they train at home. So there are researchers showing that one session a week, for example, are one or two are rarely enough to rewrite a stubborn habit. So sometimes we advocate for high frequency therapy, but the parents, when they are well trained and they cooperate and they train at home daily, we have very, very nice results from therapy. Next slide, please. So we need to focus on connection, not perfection. And so, because we are not ignoring the fact that VPI can be present, but we still do something about it, thinking about intelligibility. So Eduardo just said, you can teach the child the articulation better, separate the issue, so let the surgeons fix the hardware and the speech therapist the software, and don't wait for perfect physical structure to start building perfect communication habits. Okay, so I think we'll go back to Eduardo now.
Thank you, Melissa. Next, please. Okay, so like Melissa said, sometimes when we have VPI, we may know that there is still something to do. So we have to settle realistic therapy goals. The first goal we have to settle is the improvement of the intelligibility, not to work on the normal resonance. So the primary therapeutic goal is to maximize how well the listener understands the speaker, how it understands the patient, not to normalize the resonance. So in structural VPI, normal resonance may be unachievable without surgery. So that's very important. The second goal is, like she said too, is to improve the communication, participation, and effectiveness. So can the child be able to communicate their needs at home or at school? Are they able to engage in a conversation? Can the teacher understand them in class? These functional outcomes matter most. So the therapy must be a therapy, or how can I oriented. So the therapy can be focused, yes. The therapy can be focused, must be focused on the communication. So after the patient is able to articulate, to know the right placement, we have to improve his ability to communicate. Because some children, because they were not able to talk before, they may not develop the communication abilities and take part of the conversations. As a practical goal examples, the child will increase intelligibility to 80% with even with unfamiliar listener in a structural conversation. The child will use correct articulatory placement for the p, b, t, d, s, z, sh, j, j in connected speech in 4 per 5 opportunities, even if those sounds are not correctly made. The child will successfully communicate a third-part request to a new communication partner. So that it is very important. That means that it is important to work on the communication and intelligibility, but not focus on the reasonness. Next, please. What therapy should target? Like I say, articulation accuracy, make the articulation accurate. So articulatory placement and manner must be worked correctly during the therapy. So please target correct place and manner of each sound. Correct the compensatory articulation errors. If the patient is making a glottal stop, that means that he is using his how we call it in English, pharynx, cord vocal cord. Yes, he's using his vocal cord to make the sound. So we have to make him be aware. The patient must be aware that the sound, like the stop sounds, must be made in the mouth, not here, not in the throat. So that's a very important to teach to correct the compensatory articulation. Focus on where and how sounds are produced in the oral tract. If it is a p sound, it's very important to show him that the lips are involved, and so and so. The airflow use and pressure management. Even if we know that with VPI, there will still be a challenge to making the airflow passing through the mouth. It is very important to teach efficient use of available oral air pressure. So using the strategy like a tissue strategies is very important to help the patient seeing the pressure of the sound. By closing his nose, even if we know that after removing the hand, there will still be a problem, by closing the nose, the patient will appreciate how the air passes through his mouth, and then that will change a little bit something. So use those strategies to maximize oral airflow for pressure consonants. A light articulation contact is important to reduce the effort. Intelligibility strategies. We here want to talk about three intelligibility strategies. The first one is the rate reduction and the clear speech technique is. There are speaker-based strategies which include the modifications the patient with VPI makes to improve how well they are understood. So we can make the child articulate slowly to reach target positions in order to reduce the consonant distortion and the co-articulation errors. We can also help the patient to increase oral openings. We can also help the patient to increase oral opening when talking and exaggerating the consonant placement during communication with someone. The second intelligibility strategy in VPI we can work on is what we can call the listener education and repair strategies. These strategies address the communication partner's role and how breakdowns are handled when they occur during the conversation. That includes it includes to train the listener, like family, to understand the nature of VPI speech. They must know that hypernasality issue is not a cognitive issue, it's not a speech, it's not a health, how do you say, a hearing impairment. So they must know that it is very important that to speak, to converse with the patient every time. It's important to make the listener recognize the speaker, I mean the patient's pattern, the way he used to talk. That include that they have to face the patient directly to minimize background noise and watch his face and his gestures when he's talking. So, for example, we can ask the patient to, when he's talking, to repeat himself. So the patient will simply repeat his sentence. He can also make a revision of his sentence when it is not clear. So the patient will rephrase the sentence. The listener can also make an effort, uh, like trying to make sure he understands what the patient is saying, like asking him, "Did you say you want water?" So that lets the child be considered in the conversation. So it is also the third intelligibility strategy I want to talk about is the context and topic support for communication partners. This is about a preloading the listener with information so they can better decode imprecise speech before or during the conversation. So the patient or a facilitator or someone else can briefly announce the patient wants to talk about before engaging the conversation. So the patient can say, "I'm going to tell you about my weekend." So that gives the listener, more information about what he is going to talk about. That allow him to more interpret um, his um, his words. Next, please. Avoid non-speech oral motor exercises. This is an important topic. I remember last time I was listening to a big surgeon who is an international one, but who indicated non-speech oral exercises as exercises which can be used to help patients face correct speech issues. Next, please. So that's very important to come back on this. We have to know that there's no evidence that non-speech oral motor exercises strengthens velopharyngeal closure for speech. The mechanism which are involved in those non-speech oral motor exercises are different for the speech mechanism. So bringing a child to blow bubbles, to use a straw, to make tongue exercises, to puff cheeks, and to make lip trills, raspberry, to make chewing exercises is not helpful when we are talking about VPI. That is very important to come back on this because I know that there is still many speech therapists who maybe because they don't know that some techniques to handle the VPI speech therapy, they think that the patient can use those exercises to become better or to improve his speech. Next. Okay, I'm going to share with you three cases, three of my patients. The first one, you may quickly realize that he is potentially not going through a VPI, but the second and the third one, yes, probably. So we will see together what the speech look like during the first assessment and after many months of rehabilitation. So this first case, Sami, is a 5-year-old child who has a good resonance even during the first assessment. There's no apparent nasal air emission, but articulation difficulty on all consonants has been observed, and he has a co-articulation on P and B. He did a glottal stop, but there is no structural anomalies. There are no structural anomalies. Can you play the video, please? The first one, please.
La voix apparut.
Le bébé boit le lait.
Le bébé boit le lait.
La tortue tire Toto.
La tortue tire Toto.
Le dos dodu et les 10 doigts.
Le dos dodu et les 10 doigts.
Le coq crie cocorico.
Le coq dit cocorico.
Le gros gorille et la guêpe goulue.
Le gros gorille et la guêpe goulue.
Okay, Okay, so this patient has been trained for 6 months. We normally make one week session, one session a week, but he's not he doesn't attend the session at every time, so his regularity is something like 60% of the time during the 6 months. We target P, B, T, and D sounds. Even if we only target those sounds, he recovered spontaneously the K, G sounds. So apart of the P, B, T, D, he recovered the K, G sound, and all the glottal stop disappeared. Can you play the next video? Papa pèle la poire à Paris.
Papa pèle la poire à Paris.
Le bébé boit le lait.
Le bébé boit le lait.
La tortue tire Toto.
La tortue tire Toto.
Le dos dodu et les 10 doigts.
Le dos dodu et les 10 doigts.
Le coq crie cocorico.
Le coq crie cocorico.
Le gros gorille et la guêpe goulue.
Le gros gorille et la guêpe goulue.
Solal et Cécile sont assis ici.
Lola et I O A I.
Great. So, like you see, the next sounds are not already perfect, but he is improving very well. But I think that because he is still in treatment, I think that he will get better with the next step of the rehabilitation. So the next patient, next please.
Papa pèle la
Oh,
poire à Paris.
next. Okay. The next case is Brian, 7 years old. He has been treated for 10 months. Okay, compared to the other who has been treated for only 6 months. This boy has been treated for 10 months. At the first assessment, we noticed directly the hypernasality. He has a non-audible nasal air emission. He has issue with articulation, especially or issue with all of the high pressure sounds, and he make a co-articulation on P and B. He has a glottal stop, and we noticed that he has an alveolar fistula, which is not already repaired. So he's regular than the first boy, 70% regularity. We target two sounds, two objectives, TB and TD. We note, can we play the first video, please? I forgot.
Pauline peint un papillon. Ta tata et ton tonton t'aiment. Denis dort dans le dodo douillet. Barbara baigne le beau bébé. Le sel est sur le saumon. L'oie va voler en hiver.
Okay, you
La
can stop
jolie
here.
Jeanne aime jouer la poire à
Eduardo, are you there?
Yes, I'm there.
Okay, perfect. Sorry. Would you like me to play the next video?
Yes, the next video, yes.
Great.
Sorry.
Paris.
Papa pèle la poire à Paris.
Le bébé boit le lait.
Le bébé boit le lait.
La tortue tire Toto.
La tortue tire Toto.
Le dos dodu et les 10 doigts. Le dos dodu et les 10 doigts.
Le dos dodu et les 10 doigts.
Le coq crie cocorico.
Le coq crie cocorico.
Le
Stop, please.
gros gorille et la guêpe goulue.
So you may notice that he is able to do the correct position, the correct placement for the P, B, T, and D sounds, but there is still a persistent hypernasality and nasal air emission when he is talking. So we can understand now what he's saying, but he still has a difficulty to speak. So his speech is not correct. The last one, please. Next. This boy is a 8 years old boy. He has hypernasality, audible nasal air emission, and issue to articulate. He has alveolar fistula too, and class 3 malocclusion. So, can you play the first video? He has already
Pauline
done
peint
10
un
months also.
papillon.
Mon nom est un papillon.
Ta tata et ton tonton t'aiment.
Ha 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 et ton tonton t'aime.
Denis dort dans le dodo douillet.
Denis dort dans le dodo douillet.
Barbara baigne le beau bébé.
Maman
Le sel est sur le saumon.
So can we move to the next video? Yes.
Papa pèle la poire à Paris.
Papa pèle la poire à Paris.
Le bébé boit le lait.
Le bébé boit le lait.
La tortue tire Toto.
La tortue tire Toto.
Le dododu et les 10 doigts.
Le dododu et les 10 doigts.
Le coq crie cocorico.
Le coq crie cocorico.
Le gros gorille et la guêpe goulue.
Le gros gorille et la guêpe goulue.
Solal et Cécile sont assis ici.
Solal et Cécile sont assis ici.
Pauline peint. Papa pèle
It's okay.
la.
It's okay for the videos. Thank you very much, Darcy. So, like you notice, he has a biggest challenge comparing to the others. But I chose this case because has a personal a relationship with his family. His mother is very engaged, and at we during the first 3 months he was not able to make a single sound, even if the placement of the sample. And I told the mom that to be how can I say, to be still engaged, yeah, not to be discouraged. He will get better. Even if I know that he needs surgery, he will get better. So after 6 months, she was the one who make first the change, because the child make himself understandable by everyone, and at school he's getting confidence, even if we all know that the hypernasalization is still persistent. Thank you. Melissa? Yes.
So now I'm going to show you Denise, this amazing Brazilian boy who is actually now a teenager. And he arrived at Centrinho when he was 3 months old, coming from Bahia, a state in northeast region of our country, presenting a left unilateral cleft lip and palate. So lip repair was performed at 3 months and palate repair 12 months. He had a small palatal fistula that was closed when he had the secondary lip repair at age 9. So when he was around 4 years old, the first formal speech assessment was performed, and the main finding was compensatory errors related to BPD, consistent with glottal stop in most oral sounds. There was an important intelligibility impairment. In oral exam revealed the short palate, velar movement was reduced and asymmetric, and the pharyngeal walls also showed reduced constrictions. And then speech therapy was started, and nasal endoscopy was also indicated. So this is a different case where we used both the correction of the software and the hardware. Okay. Next one, please. Yes. So a speech bulb was fitted when he was 9 years old, and the process of bulb production started after a period of speech therapy, and it happened twice with different bulb size, comparing daily use and training prosthesis, with the training one always smaller, thus demanding extra efforts to produce normal speech, and so helping improve even better the velopharyngeal closure. He also had a dysphonia, which was also assessed with the ENT, and a vocal cyst was identified. So the main goal of the speech therapy have been the correction of compensatory mistakes, right? The active errors, and the development of VP closure. improving so that the patient's perception, production, and also of some vocal exercise. So he was trained to practice the target consonants in increasingly difficult phonetic context, just like we saw the stairs, right? So with isolated sounds and then syllables, words, sentences, and then spontaneous speech. We can see, I think next slide, the video showing his evolution at some point. Okay, so let's watch this.
Papai olha pipa, o tatu é teu, cacá cortou o cabelo, a babá beijou o bebê, o dedo da Duda doeu, o saci saiu cedo. Pá, pá, pá.
So now he's not using the prosthesis anymore because he got eligible for the pharyngeal flap surgery. And so speech therapy still continued. And he, just like Eduardo showed his case, he's still in treatment. And that's it, I guess. Next slide, please. I'm not sure. Oh, yeah, just how we thought now, right? So to conduct this case, so we started speech therapy, the evidence-based route, the lower one. And then just like I said, right, the stimulation of the VPI mechanism and gradual bulb reduction. And then we got the stimulation of lateral pharyngeal movement. And then he was indicated for the pharyngeal flap surgery for complete speech rehabilitation. So that's it. Thank you, Darcy, for the slides.
Thank you. All right, and now I will turn it over to Dr. Kate.
Hi, everybody. Wow, Eduardo and Dr. Melissa, those were fantastic examples. Really, really nice to see. I have a couple of questions, and I guess I had one maybe to start off with Eduardo, and then which is, I have it right here. What clinical signs help you determine whether a child is stimulable for improved airflow or pressure consonants? So what are those clinical signs that help you determine whether a child is stimulable for improved airflow or for pressure consonants? Eduardo.
Thank you, Dr. Kate. I don't know if we are talking about the VPI or VPD as general, but I will try to answer the question in these two situations. I think commonly the first thing that help to know if the child is stimulable is the ability the child has during the assessment to make at least a single high pressure consonant if it is a VPD. But if the child is going through a VPI, which is a structural problem, we know that the high pressure consonant may not be addressed, but his ability to at least copy the placement. Yes. So to repeat the placement during the assessment show us that he is able to improve.
Yes, great. Thank you. Thank you. Jackie, can you give, Jackie's at a cleft team in Oakland. Can you describe how much work how many trials it takes, how many sessions it takes in order to make that differential diagnosis between velopharyngeal insufficiency, as Melissa and Eduardo spoke about, and velopharyngeal mislearning. How long does it take you to get to that point? Or do you have any tips for us on how to make that differentiation between velopharyngeal insufficiency requiring a surgery and velopharyngeal mislearning, which would be the speech therapist realm?
That's a great question. And I think for people that are maybe a little bit newer, it's okay if it takes you a little bit more time. Um, I would say for some, and it kind of just depends on the child. For some people, I think kids that are probably or older kids that are more cooperative and can participate in like a full assessment and can participate in dynamic assessment, you can determine that just like in your initial assessment, I would say. If you go through all phonemes and you do different tasks with them as cueing them to use oral consonants, and after a good amount of tries, if they're completely unsuccessful and you're noticing hypernasality, weak oral pressure, nasal air emission, if you put like a mirror under their nose, and if you review your articulation assessment and they don't have mislearnings for the most part, you can be pretty certain that they have structural VPI. So I would say for that kind of patient or child, you can determine pretty quickly. I would say for some kids that are little or have neurodevelopmental differences, and you're getting these kind of like sparse productions, it's very play-based. I would give those kids a little bit more time, get to know them a little bit better, and see with cueing and just familiarity with you and your therapy room and things like that, or therapy setting rather. Um, you can do like a trial of therapy to determine whether or not they're stimulable for improved like oral pressure. So I would say to answer your question, like how long does it take or how many sessions? I would say it depends on your experience level and the patient's like ability to participate in your assessment. But overall, if you're new, um, give yourself some grace and don't be afraid to take a little bit of time. You don't need to decide immediately like they have VPI or they don't have VPI. It might take some cueing and assessment, dynamic assessment.
Thanks. By the way, if you want to put some questions in the question box, feel free. I did have another question. I know Melissa and Eduardo both talked about, the engagement with the parent, and I thought that was so cool, Eduardo, that you were able to keep the mother engaged and believing that this was going to happen, even though it took 6 months for the corner to turn, and then this amazing outcome. Melissa, I know your work, and I know how engaged you are with the families. Could you talk a little bit about how you explain to the families the difference between improving intelligibility and fixing hypernasality? Because often I find that the parents come in and they say they're so nasal, and that could mean anything. So I wonder how you would explain to families the difference between improving intelligibility and fixing hypernasality, which of course is in quotes because we as speech therapists can't do that.
Yeah, thank you, Kate. Yeah, the hypernasality for them can mean like anything, including hyponasality sometimes. So I try to explain that, but some parents they engage more in the explanation, and some of them work in the health area, so it's easier because I talk to them. I want you to become a little bit of an SLP, and then I teach them a lot about our specialty. So I think this way we can bring them closer because they understand what's happening. And it's very variable because families are very different. So you have to really get close to them, get to know them, and design a way to teach and to show them, to bring them to therapy. So I put them inside the therapy and then I showed the exercises. I think this works for most families. Of course, there's parents that they bring the kid and then just go outside because they have to do something else. and that's okay. So I think I don't have a general answer because I think it's very particular of very different realities they bring. But I usually like to explain a lot. I invest so many time. I have one session just with the family so I can teach them so they can understand, they can listen to, and they know why we are proposing that exercise and what to expect. So I don't know, Eduardo, how do you do? But I talk
Eduardo,
a
Yes,
would
to,
lot.
yes,
Jackie
to,
to
No.
add
yes, yeah,
about getting those families to understand the difference
Yeah.
between,
yes.
kind of a speech work intelligibility in that way and fixing hypernasality, which is obviously not our role.
Yes, me, I used to I have a trick during the first meeting with the parent. I I sh- I closed the doors of the child and I made him pronounce the sounds. So the
Yeah,
parent noticed that he can he can make the sound correctly. Uh, and then I showed them that it is because I remove the problem. When I do that, I remove the problem. And so that problem can be solved by surgery, by surgery. But the intelligibility improvement needs the therapy. And
yeah,
so even during the therapy, the first sessions, I make the child make the sounds, and that encourage the patient to be involved. Yes.
yeah, yeah. That's great. Jackie.
I'll just add too, in the first session, I'll often ask the parent and the child, like what their goal is for speech therapy. And oftentimes people say, "Oh, I want to communicate more clearly."
Mhm.
So then we can kind of collaboratively agree like what the goal of therapy is and then what a realistic outcome might be. And it then helps you kind of explain the difference between like what we can control in therapy, which is movement of the articulators, directing airflow, and then what can't be controlled, which would be like general hypernasality from a structural issue. And then you can say, oh, that, I totally hear you, that that's something you want to address, that, I can refer you to a surgeon who can address that. And then if you don't have access to that, then you can kind of emphasize like, this is what we can control in the therapy room, and I'm so excited to work with you on those things. So I
Yeah,
think that can be a way to like manage expectations and create a realistic goal.
that makes sense. Um, One person asked in the chat, and I think maybe we could talk for a bit about imaging. Is there any place for video fluoroscopy or video fluoroscopy, magnetic resonance imaging, MRI, or nasopharyngeal endoscopic studies? So I don't know where you all are on that in terms of your settings and what you'd like to comment on that. I don't know how many are any of you of the three using MRIs, using Jamie Perry's work in MRIs or video fluoroscopies do you use or nasoendoscopies? I know Dr. Siraj just did a wonderful 3-day intensive seminar on VPI in Kumasi that I heard was fantastic, Dr. Siraj. But anyway, I'm opening that up to you, the kind of imaging you might do in your centers.
Can I start first?
Please.
Okay. Yes, I have learned very very well from Dr. Suraj about nasal endoscopy, which is very important to the assessment of VPI and to locate the accurate cause of the VPI. But in Africa, in generally, in my settlement, in my practice,
Mhm.
there's no way, there's still no way to yes to use a fluoro video and so and
Mhm.
nasal endoscopy, even nasal endoscopy, we don't have it, we don't still have it. So when we make the oral examination and we see that there is a structural problem, so we are sure that is the VPI, but we don't have the means to determine that is a VPI related to a submucous cleft and so and so.
Mhm. Melissa or Jackie?
Here in Bauru, we use both nasoendoscopy and video fluoroscopy, being the first one the main choice for most cases because we have a direct vision and we can also use it as a biofeedback for some patients. But then secondarily, we use video fluoroscopy for younger kids that do not cooperate with nasoendoscopy, and also for assessing the tone position, if it's participating or not of the velopharyngeal mechanism. But we have both. And now the as we are turning to a general hospital, now this year we have the MRI machine just arrived, and then we're thinking about starting this kind of assessment as well. But
Jackie?
for now, just yeah.
Sorry. Yeah, sorry, Melissa.
For now, we use nasoendoscopy, but there's certainly lots of great work with other types of imaging, including MRI.
Yeah, good. We have two questions from Swetha Srihar from India. And this, I think, is an interesting one. Does the decision-making process for therapy, for speech therapy, differ based on the size of the velopharyngeal gap? So does the process for speech therapy, what sounds you're going to work on and how you're going to do it, differ based on the size of the velopharyngeal gap? So I guess that would be if you did imaging before the therapy, maybe. Anybody like to speak about that? Does the decision-making process for therapy differ based on the size of the velopharyngeal gap?
I can chime in.
Sure.
I would say in some ways yes, in some ways no. Regardless, like size of the gap shouldn't stop you from starting therapy. So in that way, like it's not a barrier whether they have a large gap or a small gap. Um, which I think a lot of the times people feel like, oh, they have severe structural VPI with the large gap, we shouldn't treat. But as we saw in the presentation, you can always treat uh you can always work on articulation despite like a structural issue. I will say, like, I think in some people's like algorithm of determining therapy, if someone has a really small gap and maybe a few mislearnings, you can trial some speech therapy and then reassess the gap. If you're needing to do some dynamic assessment, like, is this an articulation kind of error? Or is this something that's structural? So that could be one time where that maybe could inform your treatment. So that's the answer to the first question. I don't know if anyone else wants to chime in.
I mean, can I? Yes, I just want to make sure that there could be two kind of gaps. There are some when we make oral examination, we can see that there is a gap between the velum and the posterior pharyngeal wall. But even with that, the patient is able to make the sounds. So I have some children like that. They looks to have a gap, but they are able to make to use the velum. So they may need a training to learn how to use the velum. But if the gap um, is related to a short velum, and then the velum is not able to make the closure, they will still need a surgery. But in the two cases, in both the cases, the therapy must start.
Yeah. Yeah, I think I think that's the underlying thing for me too. What we've all been saying, the speech therapy, if there are speech therapy issues, if there are compensatory errors, cleft speech characteristics, we do the speech therapy because the question for this seminar was, do you treat when you know there's VPI? And we've been talking about understanding the difference between velopharyngeal insufficiency, which is a surgical situation, and then velopharyngeal mislearning, which is a speech therapy situation. And often we can find children who we know have VPI, but continue to have mislearning errors. And what do you do during the process where now you know the child has velopharyngeal insufficiency? You know they're going to get a speech surgery, a secondary surgery on the palate. And the question is, do you continue to work? Once you know that for sure, you've done the nasopharyngeal endoscopic study, you've got, the sounds in good, correct articulatory placement, they've gotten good speech therapy from you. Now you know VPI, surgery. What about all the other sounds that are compensatory errors that are still there? Like we even saw it with Eduardo's wonderful cases of the glottal stop on the ka, even though the patient got the pa, ba, and ta, da right on point. So what do you do with that? Do you continue to provide speech therapy when you know the child is going to get speech surgery to address the velopharyngeal insufficiency, yet the child continues to present with compensatory errors? Dr. Melissa, can you answer that question that people have?
Yes. Sorry, this is a sweet question. Oh, no, it's your question, right?
Yeah.
Okay. Yes, we do. We just need to adjust the what we do, where we're doing, where are we going. So we can have different phases of speech therapy, right? So yeah, the answer is yeah, we continue addressing this articulatory errors, and but what to expect in the end of these sessions. So that's the difference. I think this applies also to the question of the VP gap, the size. If you know that, you know what to expect better from the therapy, right? But you don't interrupt it because of the size of the gap or because the patient's waiting for surgery. Yeah. I don't know if I answered your question.
No, you did. You did.
Okay.
Jackie, you have anything to add there?
I would just add to like speech therapy, you're working on a team. Even if you don't get to see a surgeon regularly, like in a way, you're still a team. And so speech therapy is really important, and surgery and speech therapy can be very complementary. So the surgery is not the end all be all, and it can be very disappointing to families too. If the child goes into surgery with a lot of compensatory errors, and then they have the surgery completed and their speech just remains very unintelligible, which, can just, that it might just have to be that way. But the idea of starting therapy before surgery is you're already starting to address those compensatory errors, and the surgery can work that much better. And that's like the complementary part of like the speech therapy and the surgery, and then speech therapy can continue after. And so starting the speech therapy ahead of time not only helps like start to address compensatory errors, it gets the child familiar with the therapy process. It allows time for parent education of like what a realistic outcome for the surgery might be. So just hammering home, I think, like the point of this presentation, which is that just because there is a structural issue with the palate, it doesn't mean that you need to withhold speech therapy or not start until that structural issue is resolved with a surgery.
Yeah. And then once you give them sufficiency with surgery or prosthesis, they improve very fast once you've been treating them before surgery, right?
Eduardo?
Yes, like the others said, like I think when I know that it's a VPI and the assessment is made, the only thing that remain in as a therapy goals is to target the rest of the placement and to correct the compensatory errors. I know that even I make all my efforts, there's no way to correct the resonance issues.
Yep. Yeah, good. Um, uh, Helene Somerville from England had a suggestion, which I think is adorable. I've done it. Even my graduate students, I make them do it. You know, replace the s with the g and do that because that's really what we're asking them to do. And I think it's a real life. I think, Eduardo, you mentioned something like this as well. You know, have the parents get a real life understanding of what it's like to do this challenging task we're asking these little kids to do, which is to change the actual placement of their sounds and how they hear those sounds too. Let's see, Siraj. Yeah. Oh, the velo. Sarah, do any of you use the velo, the velopharyngeal evaluation of language outcomes? Do any of you use that? It's from Seattle Children's Hospital. Yes, Dr. Melissa, can you talk a little bit about that?
No, I was just coughing here. Sorry. I just trying to tell you I don't use it.
Oh, you don't use it.
No, I don't have any experience. I'm
Yeah.
sorry.
Jackie, do you use it?
I use it sometimes when it seems like someone is kind of uncertain of how they want to proceed.
Mm,
There, or maybe I think they might be withholding and a child doesn't want to verbally say what's going on with their speech
yeah.
or how it's bothering them. There's also the cleft cue. I know that's another example. So I would say sometimes I'll use like a written questionnaire case on a case by case basis.
Yeah. Yeah. The bellow, just for everybody who doesn't know about it, Sarah put it in the chat, but it does ask, you know, are they understandable, that kind of stuff. But they also, you know, how does the velopharyngeal um, cleft that they have, or how does it affect their lives? Are they bullied? Can they participate in school? That kind of thing. So it's from a psychosocial point of view, it's a very important instrument. Eduardo, do you do that or do you do any of that? Do you do the intelligibility and context scale from Sharon McLeod from Australia or any of that when you're talking to parents, or do you just have a conversation with parents about the impact of the cleft on their lives?
No, I'm not sure. I'm not sure I have a good understanding of that.
Yeah,
So I can't tell you if I do that or not, but
yeah.
I'm not sure. I'm not sure.
Do you, how do you explain to the parents what's going on and find out what the impact of the cleft is on the child's life? And this will be our last question.
To me, I suggest, I think. Is it a question to me?
Yeah, Eduardo, how do you explain to the parents
Yes.
what's going on and the
Okay.
process?
You know, in our situation, this is the big issue we have because many of our patients have VPI,
Yeah,
and maybe because they even have a second surgery, and well, that is due to many situations. So I'm not going to talk about that. But we used to face those kind of situations. But what we tell the parents is to help is to see the change that is occurring in the child in the child life. I mean, before the treatment and after the treatment. So even if we know that the child, we tell them that the child may need a second operation or a second intervention before getting a perfect speech. So
yeah,
before getting that, we help them appreciate um, a small, if every single shift that is occurring in the speech of the child. So I don't know if I answer your question.
yeah, you did. You did. You
Yes.
did.
Okay.
It's a great way to end with the conversations with the parents. So thanks to Smile Train, to Darcy and Sarah for inviting this. Thanks to everybody who's come. Turn it back to Smile Train. And thank you, Dr. Melissa in Bauru, Brazil, Jackie in Oakland, California, and Eduardo Jason in Benin. Thank you to everybody. Darcy and Sarah.
Thank you all so much. And Dr. Crowley, thank you so much for moderating and for all of you for sharing your insights and everybody for your engagement in the chat. Before you go, we do have one final poll just to get some information about this seminar and your thoughts on it. So please feel free, please submit this. This helps us craft better seminars going forward. We're very excited that this is now a part of our speech offerings, and your feedback helps us make these a valuable resource. Again, sincere thanks to all of our speakers and presenters. Your expertise is greatly valued, and we look forward to seeing you all again. Anything you want to add, Sarah?
No, thanks
Thank
so
you,
much.
Darcy. Thank you very much.
Thanks for filling out the
Thank you so
survey.
much.
Bye, everybody. Take care. Have a